Hi, this is Souvik Roy, consultant physical therapist, R N Tagore Hospital, a unit of Narayana Health. And I would like to welcome you all in today's live session, which is on awareness program on physical therapy and rehabilitation. As today it is 8th September, we all know it's observed as World Physiotherapy Day, where we would like to appreciate the critical contribution of all the physical therapists across the globe in restoration of normal movements, which eventually help people move independently in their day-to-day life. So, and we have our guest speakers with us. We have Dr. Surya Udai Singh, sir, Head of Ortho and Joint Replacement Program, and also Head of Department of Physical Therapy and Rehabilitation. Sir is well known as he is pioneer in the field of joint replacement also. Sir, we welcome you in this program.
Thank you.
And towards my left, we have Dr. Kosik Sundasa, who is a stroke and interventional neurologist. And we all know that how critical job sir is playing, like when patient came into the emergency department and he's restoring the blood flow to the damaged part of the brain, and which eventually help us even to carry over the patient from that part. Welcome you, sir.
Thank you.
And towards my right is my senior colleague, Mr. Bodhottom Banerjee.
Hello.
He is manager of Department of Physical Therapy and Rehabilitation. So, without making any delay, let's move forward. Like, we have some random questions which we got from our clients, and also we have also doubt in our like day-to-day clinical practice. So my first question to you, sir. Sir, nowadays joint replacement surgeries have become very common. After certain age, people are complaining of pain in their knees, and they want a pain-free life, like they want to lead a quality life. So they opted for this joint replacement surgery. Sir, what do you think regarding the importance of physical therapies after such joint replacement surgeries?
So Souvik, you said about the quality life.
Yes,
if
sir.
you say about the quality life, then when you don't need the exercises, it's never.
Yes, sir.
It's not about the surgery only when you need it. It's about the day-to-day life, and it's about the quality life. If you want to live a quality life, yes, you have to do the exercises on daily basis. That is the first thing. Second thing, why everybody put stress on to do the exercises and rehabilitation after the surgery? Because if your joint is damaged, then you did the surgery. It means it has been some time when you lost some of the functions of the joint. So your muscles might be weak, your range of motion might be less. So why you need? Because you want to regain it. If you want to regain it, definitely you have to do the rehab program. Otherwise you cannot. So nowadays with the technique, with the design of the implants, you can regain 100% of the movement. So what we need after surgery, suppose it's a mandatory. You have to start the exercise and rehabilitation after 24 hours. So there are 4 things which you have to do. First thing, you have to gain the range of motion. You have to start it. Second, you have to start the strengthening exercises. Because of pain, you might that patient might be moving less. So muscle power will be lost. So you have to regain that. So this is the second thing. You have to do the cryotherapy immediately, because after that, after surgery, your joint will be hot, so you have to cool it down. And the fourth one is your whatever you did, you want to move properly. Suppose climbing stairs, coming down. So there are few particular exercises also in day-to-day life which that patient might not be doing because of the pain. So you have to start that also. So there are 4 or 5 things. You have to train them, you have to start immediately. And yes, rehabilitation is very important part of any surgery. As a surgeon, I can say I do only 10% of the job. Rest of the thing patient does. If the patient can do by it alone, then it's okay. The only question is whether they need physiotherapist or not. gear may be down. Yes, if the patient can do, they might not require. They might not require the physiotherapists or some helping hand. That does not mean they don't require the rehabilitation and physiotherapy. You have to do it. Maybe by your own, maybe with the help of someone.
Thank you, sir. Explain such a nice explanation. Sir, I would like to add a little bit more on this. Very oftenly we hear in this like such things. Like, is there any such kind of implant or such kind of knee replacement surgery where no physiotherapy is needed post-operatively? Is it true or?
It's something written in the literature I haven't seen till now. Any design says that we don't require any rehabilitation program. Any implant or any machine cannot move by itself. Even if you are driving a car, it's everything loaded, petrol, tires, everything is loaded, but you have to drive it. If you don't move it, they are not going to get a movement. So why this question comes and where it is written? And if it is written, but why it is written and how it is written? It's not. If you have to move something, then you have to move it.
Thank you, sir. Thank you. This is what we want to hear from you. Like the expert who is doing all these surgeries day and night. It's better to hear from you, sir. It's cleared our doubt clearly.
Thank you.
Thank you, sir. Sir, next question goes to you. As your specialization in management of stroke, like in day-to-day life, whatever you are doing, like intervention. Sir, as we know that stroke is one of the leading cause of death and disability. If we talking about death, it will be good like premature death and disability. So, what do you think, sir, the importance, the critical role of physiotherapy in stroke management?
Thanks, Souvik, for the question. I cannot stress upon this more than what I'm saying right now, is that physiotherapy and rehabilitation is quintessential for stroke management.
Yes.
Many patients think that if they take medicines, they recover from stroke. But I would like to put it on record that most of the medicines that we take for stroke is actually preventing another stroke from occurring. So we say we have BP medicine, we have medicines for sugar, or we take blood thinners. You have heard these words, antiplatelets, ecosprin. They prevent another stroke from occurring. But if you want to recover from the stroke that has already happened, then physiotherapy and rehabilitation becomes very important. Now, most of us know that we use very little part of our brain, 8%, 10%. That's, the word is still out. We don't know how much of brain we use. So what about the rest of the brain? So I believe, this is a personal view, that is the reserve brain, So whenever a particular part of the brain is damaged, then the other parts start taking up its function. For this, you need to stimulate that part.
Yes.
And physiotherapy and rehab helps that. So the more rehab you do, the more new parts take over the function and the patient becomes more functional. So I think rehabilitation is very important for a patient to recover from stroke. And medicines are more important to prevent another stroke. I hope this is very clear.
Amazingly explained, sir, like the process of neuroplasticity you are telling and
Correct.
the process by which we rewire the brain, the
Correct.
physios are involving into.
It's very important.
Thank you, sir. Thank you. So my next question goes to my senior colleague, and coincidentally this time the theme of this World Physiotherapy Day is long COVID and its complications. So it's all regarding this only. So what do you think the role of physical therapy in COVID pandemic? So many patients are, so many deaths, so many patients are suffering from this COVID pandemic. Not only suffering, even after getting discharged from hospital, they are suffering from secondary complications and again getting hospitalized. So how physiotherapy is helping this patient to get recovered from COVID?
See, Souvik, COVID affects our lungs. So there is something very common with all these patients, that is breathlessness. The first goal of physiotherapy is to reduce breathlessness and to improve the exercise tolerance and improve the quality of life. So how do we achieve it? We achieve it in two ways. First, we have to find out there are two categories of patients. One, they are very critical. They are under the support of ventilators. Physiotherapy plays a limited role there. You have DVT prophylaxis, passive movement of exercises can be done to prevent joint stiffness. Then you can go ahead with chest physiotherapy, clearance of secretions, and prone position. This is limited over there. Now you have another set of patients who are gradually recovering. They are on the verge of going home or they have gone home. Now they have a little bit of breathlessness and little issues with breathing. So there comes the role of our physiotherapist. So how we do, we start with breathing exercises. So we have different categories of breathing exercises like diaphragmatic breathing, pursed lip breathing, followed by resisted breathing exercises. Then once the breathing part is taken over, we concentrate on the coughing part. Some of the patients have problem with bringing out the secretions. Productive cough is there. So we help them, teach them techniques to cough out properly. Next comes the mobility part. Because these patients were isolated, they were on bedridden state, they did not move because movement causes breathlessness. So they didn't move properly. So now we will start with assisted mobilization in the form of assisted exercises, followed by active exercises, then progressive resisted exercises with little bit of weights. Followed by, we will focus on aerobic training. Once these resisted exercises are done and they are gaining strength in their muscles, the joints are quite free. Now we will concentrate on the aerobic exercises. The best example is to walking. So there should be, the exercise session should be shorter, low intensity and short duration exercises. You cannot expect that these patients will go home and start doing exercises suddenly and they will gain strength and confidence. So everything should be in a graduated fashion. So practically we have seen after doing exercises in this manner, most of the patients are leading a very comfortable life after COVID.
Thank you, sir. We have seen patients like those patients who are admitted with COVID pneumonia and recovering, still like after some a little bit of recovery, when we ask the patient to do a little bit of minimum activity, then also we see a sudden drop in the saturation level. So how to deal with such things when we are dealing with COVID patients?
Then comes the, we should give oxygen supplement to these patients. They should exercise with oxygen supplements. And we should have a very close monitoring system for these patients. They should not exercise alone. There should be a proper supervision and monitoring. We should constantly monitor the vitals of these patients as well as saturation level. If there is a drop in the saturation, we can increase the oxygen, but they should not restrict themselves from doing exercises. So this is how we carry over the exercise regime and patients improve gradually.
Thank you, sir. Thank you for such a nice explanation. Sir, my next question to you. So we have seen so many patients nowadays coming with back pain and some complaints of radiculopathy, like pain is going down the legs, and many of them are advised for surgery also. So do you think like with active physical therapy and lifestyle modification, ergonomic correction, these surgeries can be prevented? Because often the patient asks like, do we need surgery, or when the surgery is indicated in such patients?
Oh, so I can say either you are keeping your rehabilitation program over the neurosurgery or you want to derail your department.
No, sir.
No. Then you should not. No treatment modality can replace the another one. It's fact. If it is needed surgery, if it requires surgery, then your physiotherapy cannot help. Yes. It's a mutual, symbiotic relationship between the surgery, medication, Dr. Sundar is there, it's a neuromedicine department, neurosurgery department, and your rehabilitation department. There must be symbiotic relationship. Not like I can, okay, do the rehabilitation and exercises, you will not require the surgery. If the canal compromise is more than 50%, believe me, you cannot change the fate, you have to do the surgery. If there is a change in the card, then you have to decompress it. You need the physiotherapy also, you need the rehabilitation program also, you need the neuromedicines also. So no one can replace the another one. What you need, you assess the patient properly. How much is the compression? Is there any change in the cord or not? How much it's and similarly you have to assess the muscle tone, power, each and everything, reflexes, whatever. So there are protocols, there are definitely indications for the surgery, and yes, if it is suppose it's 50-50, you might require, you might not require, so you can start physiotherapy rehabilitation program first. do it for some time, assess the patient again, do the scans again, whether there is some change or not, there is some change in the function or not, symptoms are getting better or not. If it is yes, then go with the rehab program. And if it's worsening, or if it's not responding to your treatment or your rehabilitation, then you go for the surgery. In the first case, if the canal compromise is too much, go for the surgery directly and do the rehabilitation. If it is, suppose in the middle segment, where you had a time, suppose you had a time, then you start the rehabilitation program first and assess the treatment process and outcome. If it is good, then go for that protocol, what you had decided earlier, don't do the surgery. If it is worsening and not getting better, then go for the surgery. Don't say that you can replace the surgery.
No, sir, we are not saying that. Like many times people come to us and there are some signs and
no,
symptoms.
there are so many things. This is the public forum. I want to give a message. It's nothing like that. Okay, somebody has suggested you surgery, you come to me and I will do the wonder. Nobody can do the wonder. Nobody can do the magic. This machine even nobody knows. I can say simple one thing. This machine is still unknown to us. Suppose if you had a pump, what you need? You have to pump a water. So you need the pump downstairs, but you never need from the top to bottom.
Yes.
If you have to send the water, then you need the pump. If you have to send from bottom to top. Okay? Have you ever seen any pump over the tanky and coming down? No. Water tank. You don't need any pump for the water tank. But here it's different. Our pump is here to send the blood to downstairs. You got it?
Yes.
But there is no pump downstairs to get the blood back. So this is a machine which we know and we are trying to know. Whatever we know, you need to do that. So nobody can replace anyone. Yes.
Whenever it's needed, sir, it's needed.
It's needed? No. Work together.
Okay.
Then you can achieve the wonders.
Sure, sir. Thank you, sir. Sir, I'm moving to you. Now, sir, another question we very frequently we are dealing with. We are in doubt also, like clients also want to know, like general public. Sir, one patient had a stroke. So, how early should he or she start the rehab sessions? Like from inpatient only, or after getting discharged, or even after a few months? Like
That's a very, I think, a very important question today, Souvik, because whenever a patient has a stroke, it is usually the relatives who are very anxious. Unlike other diseases, where the relatives also play a role, but patient himself asks questions. But in stroke, it is more often the relatives. So the moment we say there is a paralysis, they say, sir, has physiotherapy started? So when do we start this physiotherapy? And for this physiotherapy also, there is a window. We cannot start physiotherapy aggressively when the patient is in the ICU. For this, I could actually borrow what Mr. Bodhottom had told. So he said, when we have a sick patient in the COVID ward or a COVID ICU, we cannot do aggressive physiotherapy. Similarly, for a stroke patient who is very sick in the ICU, he is not in a state to follow any of our commands. And studies have shown that if you start very aggressive physiotherapy very early, then these patients take more time to recover. Having said that, if you're doing a physiotherapy much later, in the sense let him get discharged, during next OP visit we will take care of it, is also wrong. So the ideal time for starting physiotherapy would be once the patient is out of the ICU, then he is able to understand our commands and able to follow some of what we are saying, then probably physiotherapy would play a role. So definitely not in the ICUs, maybe passive physiotherapy would help. But just outside the ICU, I think we can start our rehab program.
like taking out of the patient out of the bed, like going too much aggressive, started gate training and all.
Yes, I think maybe for the general audience, they have to understand that physiotherapy has two different intensities. At least when we call passive physiotherapy and an aggressive physiotherapy. Passive is okay, like bed changing and and passive movements in the hand, that is fine. Aggressive physiotherapy, like patient is on a ventilator, they are asking us whether we have made him stand, made him sit, I think that is a bit uncalled for. It could be more harmful to the patient rather than helpful. So we have to draw a line there. And studies have shown that whatever we are talking about is established by science. So in the ICU, be passive. But once the patient is outside ICU, I think we can start aggressive physiotherapy.
Wait for some time to just stable down, like hemodynamic is stable, and
Even mentally also, you should come out of that shock,
Yeah.
and then probably we can start the physiotherapy, because it's a two-way process. You have to communicate to the patient, and the patient has to give you a feedback, and that happens only when the patient comes out of the ICU, not in any other state. So to put it short, definitely not in the ICU, but outside ICU, I think we can start our rehab program.
Thank you, sir. So, talking about COVID, sir, we have heard a lot regarding this term since we have hit with this COVID pandemic, proning. So, can you tell us like the effect of proning and how patients will do this proning position once they get back home? Are there certain postures like correct way of proning or just lying down on the stomach? So how?
See, what is proning? Proning is lying flat with chest down and back up, right? So this position has to be comfortable for the patient. So you need to keep a pillow just beneath your forehead, one beneath your chest, one beneath your waist. You can keep another pillow underneath your legs. So and your hand should be in this position so that the patient can comfortably maintain this posture for as long as 14 to 18 hours in a day. And this is approved, research have been done, and it is proved that proning helps to improve oxygenation. How it happens? The moment you prone a patient, the back of your lungs, the posterior aspect of your lungs, the basal segments, they function better. There is a better matching of oxygen along with your blood. We call it ventilation perfusion matching. So that improves. Proning also enhances the removal of secretions from the posterior aspects. So principle of postural drainage also comes here. So if you have secretions inside and you have kept a patient to prone, so these secretion moves to the central airway, and it becomes very easy for a patient to cough out, or if a patient is on ventilator, you can suck it out. So, and it helps your lungs to expand in a better fashion. But there are certain things which we have to keep in our mind. Certain contraindications are there for proning. Number one, if you have an unstable fracture of a spine, instability in your sternum, the patient had a cardiac surgery, median sternotomy, and osteoporotic bones are there, or there is a pregnant woman. So for them, you have a modified prone position, which is also beneficial, and patient can get same benefits like proning. So proning is an established fact that helps all the COVID patients with ARDS, to improve their oxygenation and vital capacity of the lungs.
Thank you, sir. I guess our viewers will get help from this. They can perform this particular position to improve their ventilation perfusion.
Yes.
Sir, coming back to you. Sir, there will be any difference in the recovery process even after joint replacement surgeries, or if there is a planned surgery, if the patient start doing physiotherapy prior to the surgery, so will there be any difference? The patient will get some benefit after the surgery, like the recovery process will get earlier, like the patient can achieve early recovery if the patient is not performing that exercises prior to the surgery.
I think so. It's a very good question, and most of our viewers knows also. Now it's an established fact. If you do what I said in the first question, you should not be out of the exercises ever. Suppose you are planning for the surgery and you had a time. It's not to do the exercises you have to postpone your surgery. Yes. Maybe for some reason you had a time and you had planned for the surgery, maybe leave or you something, whatever the reason, you had a time, then you will start the exercises. Because whatever the range of movement before the operation is achievable immediately after the surgery. Suppose if you had a range of movement 100 degree or 90 degree. So you can achieve this range of movement within 2-3 days without doing much of the effort. Okay. So what I said, why you need the physiotherapy? First thing, you have to increase the range of motion. So whether you do it before the surgery or you do it after the surgery, you have to do it. So second thing, you have to do the strengthening exercises. So you have to strengthen your muscles. You have to do it after the surgeries also, but you can do it before the surgeries also. Whatever the muscle has got the strength, that is the helpful, which you are planning to get it after the surgery. So why not the before the surgery? The last one was the gait training. The most important thing is the gait training. In any rehab program, after the surgery, which you require most? Gait training. Because your joint is always bent. Patient walk like this. You have to change the habit. Even after doing the surgery, straightening up your limb and your knee or whatever hip, patient used to walk like this. So you have to do the gait training also. So this is the fourth one which you need to do. So if you do the two first, range of movement and strengthening, then you can focus more on the gait training rather than first two. So definitely, if at a time, everybody should do.
Thank you, sir.
Everybody should be advised like that.
Thank you. So, sir, regarding this gait training, it would be nice to have our viewers, like they also will get some confidence hearing from you. So many times, even post-operatively, we are reaching the patient. And when we ask them to walk, they hesitate, like they are in fear whether to walk or not. Sir, how early we can make the patient walk? If they can hear from you, they will get confidence.
How early? It's mandatory after doing the replacement. Everybody has to work within 12 hours or 24 hours, not beyond that.
That's amazing, sir.
No, you have to make them walk. And if you want to make them straight walk, then ask them to do catwalk.
Thank you,
It's
sir.
tips to you.
Thank you, sir.
If they do catwalk, then they will walk straight.
Thank you, sir. Thank you, sir.
Welcome.
Sir, my question to you, sir, most of the time we deal with some tough jobs, like it's not always like we get a fresh case, like we always which we want, like the patient had a stroke, and if we can have access to that patient from the very initial time, so we can install some normal movements, whatever we do, like we have discussed earlier regarding the pain.
Correct.
So in few cases, like patient is coming to us after a few months, or they have spent time over somewhere else where they didn't receive that much of good rehab. So when they came to us in a bad shape with a lot of spasticity, a lot of abnormal synergy patterns, abnormal gait, so our job becomes very tough. So in that case, sir, what else can be done to make all these things a little bit easy?
I think the first thing that we need to look at is probably the awareness level among patients is very low. When we talk about stroke, we would have seen in those Bollywood movies, when they are getting the mother end with the hand like this and we think that is normal. So after a paralysis, if a hand goes like this and the leg becomes tight, it's a nightmare. It's a nightmare for the treating physician, it's a nightmare for the rehab, because the joint has lost its place and it is so tight. So the simple thing to remember would be tight means it's too late. I think tight means it's too late. If you have a paralytic attack on one side and you feel that the limbs are becoming tight, then it's too late. And we should probably start rehab when it starts becoming tight. After 6 months or 1 year, when the patient has very, very tight muscles, and we have very little to work with, because the joint, I'm sure sir will also agree, would have abnormal configuration now. You will not get the mobility that you get. There are good medicines that can help to relax the muscle a bit, but it doesn't work at that stage. Botulism is something that has come up, but the point is, even botulinum toxin that we give, Botox injections as they call it, even those toxin injections are only temporary. Unless rehab is a part of this whole thing, like where you give a Botox, you loosen the muscles up and then go into rehab, then it helps. Even then, if muscle tightness is the reason why he is not able to move, Botox will help. If there is a joint deformity that has come into place, then there is nothing that we can do. So I think that to answer this question, the awareness level for rehabilitation post-stroke should be sky high. And we should just remember that the moment that limb becomes tense, it's getting late. Tense means too late. I think that's what. If it is tight, just it's too late. Immediately rush to a rehab. See a physiotherapist, and you know about this. You have seen patients with shoulder pains, dropped shoulders they come with, and they say, So it's like a process, it's a vicious cycle. You try doing physiotherapy for them, they say it's paining, sir, we cannot move. Because they can't move, they develop, reduced range of motions, and this just keeps subluxation of shoulder, and this keeps going. And finally the relative says, sir, हाथ ऊपर करेंगे तो बहुत दर्द हो रहा है, तो physio कैसे करेंगे? So I think the idea is that rehab should start very early, and the moment the muscles are becoming tight or tense, that's a warning sign. No medicine or no surgery or Botox is going to replace rehab in stroke. That I am very clear with. It can facilitate the process, but you need good rehab very early. That is what I would say.
Thank you, sir. Just the conclusion, like time matters.
Yeah, like you cannot be too early. I mean, first day itself, you cannot expect a comatose patient to walk. You cannot be too late. When he comes in that, that position to help a rehab is also not possible. You need that window period where rehab should be a continuous process. And this is also something that I would like to add. Physiotherapy sessions are important, but home-based physiotherapy or exercises which the patient should do regularly is most important.
Yes.
Non-availability of a physiotherapist does not mean you should not do exercises. There's two different things. अगर physiotherapist नहीं है हमारे गांव पे, उसका मतलब ये नहीं कि exercise ना करें. So I think that has to also be told. And they think that a session of a physiotherapy where a physiotherapist comes for 45 minutes is enough for the day. We have to tell them that they have to do this 3-4 times a day. I think that also has to be told. So the awareness level should come up pretty high.
Thank you, sir. Thank you so much for explaining in such a nice way. Like, this is the most important part, and most of the physios also struggling with this part also. Like, thank you, sir.
Thank you.
So, sir, my next question is for you. As I told you, this time, this World Physiotherapy Day, the theme is long COVID and complication. So, the last question on COVID. So, what are the long-term complications one patient might have who had COVID, got admitted and pretty much lung involvement, and how physiotherapy is helping him or her to regain her approach normal lung function, whatever possible?
See, in our clinical setup, we have seen that a lot of patients are coming back to us. They are getting readmitted, or they are coming for physiotherapy consultation with some of the common complications, as you said. Some of them are like fatigue, chest pain, muscle pain, joint pain. They have little bit of breathlessness, persistent cough, anxiety, depression, insomnia, and some of the patients who were under ventilatory support for more than 15 days or 20 days, those people have got cognitive issues with them. So, but we have seen the patient who have been through pulmonary rehabilitation program properly, those patients who did exercises after going home, the complications are quite less. But those patients who were sedentary after reaching home, complications are more in them. So physiotherapy plays a very important role for each of them. And I will tell all my viewers that physiotherapy in the form of exercises, as I said, aerobic exercises like walking, climbing stairs, doing a little bit of cycling. We have portable cycles available, you can buy them and do these kind of cycling exercises. More of aerobics training can take care of the complications, the musculoskeletal complications. And we have specific cognitive rehabilitation therapy to deal with cognitive problems, like you have memory problems, problems with concentration. So these problems are not very common, but they are still there. So you can treat these very successfully with cognitive rehabilitation therapy. Altogether, exercise plays a wonderful role in managing these complications.
Thank you, sir. I guess we are done with all the questions, and on COVID, sir, one last question for you. We had a little bit of doubt on this orthopedic part. So nowadays we see people are more suffering on field when playing sports, and also on field physiotherapy and injury prevention. So how physiotherapy is playing a vital role in this sports injuries, management of sports injuries?
So have you ever seen any orthopedic doctor in the field?
Yes, sir.
Orthopedic doctor in the field? Official? No, I think so. They appoint the physiotherapist officially, but not an orthopedic doctor. So sports means obviously physiotherapist and their rehabilitation program. So there is definitely sports has a very, you can say, physiotherapy and sports. If the physiotherapy is not there and rehabilitation is not there, then no, the players can't play. You had seen improvement. You had seen a performance, improvement in the performance. That is first thing is skill. And second thing is their training. Training means what? Training is itself is a rehab program. Skill is there. That boy or girl may be talented, but you need to train them. And the training is everything. So the rehab and physiotherapy all are the integral part of the sports. So that's why BCCI appoint the physiotherapists, not the orthopedics. I'm disappointed for that, but they don't need that.
Thank you, sir. Thank you for such encouragement words and all. So, thanks to all of you for such a nice discussion and explaining in such a nice way all the questions. Thanks, sir.
Thank you.
Thank you, sir. Thanks. So, I guess all our viewers will get a lot of help from listening from all our special guests here, like all our stalwarts in their field. So, thank you, and I guess you all will be safe and stay healthy, stay happy. Thank you.